Okay, I'm going to stand down from here because I'm always afraid I'm going to fall off a stage. Ever since I was in high school in 12th night and was the Duke of Orsino and was doing a soliloquy on stage, as of course alone, on Friday afternoon, and all of my friends were in the front seats of the auditorium at Lincoln High School in Portland, Oregon, and I was up there doing, "If music be the food of love, play on, give me excess of it." And I stepped on my purple robe, and my knee buckled to the ground, and I fell off the stage in front of my friends, which the only real silver lining of that is it really shut them up, because they came saying they were going to make fun of me, but boy did. Anyway, so anytime, it's classical conditioning. The stimulus of standing on a stage is directly paired, like one neuron away from the stimulus of falling off the stage. So, feel better now. DBT, so this is, I think this is a reasonable sample of beginning in DBT, and it probably differentiates it from other treatment models you'll see this week. I hope so, because I'm going to get to see them too, and I think the other presenters have mostly stepped out because they didn't want to see this for understand. Then they'll be biased. They'll already know you, and they'll know what I did. So, what did I do that was? Let me say a few comments about DBT and what I think I did that was particularly DBT, and then I'd like to open it up for discussion. First thing, DBT is, it could be called, this would be close to what Anthony Bateman's presenting, DMBT, because it's really not just dialectical behavior therapy, it's dialectics, it's mindfulness, it's behavioral therapy. So that's what I'm always trying to do no matter what I do in DBT, whether I'm trying to get a commitment, whether I'm doing a behavioral chain analysis, whether I'm targeting a certain problem behavior. I am using behaviorism, I am using mindfulness, and translated usually in a session as validation and awareness. And I'm using dialectics as needed to negotiate the troubles as they come up. And I thought here that what I first am demonstrating is that when you start treatment, you orient it around that the goals of treatment involve, first of all, getting a life worth living. That is the ultimate goal of DBT. And so I always like to start very deliberately in my practice of DBT with getting that image. In the studies on executive functioning, for instance, there are several executive functions. And this one executive function is to be able to envision the future, a desirable future. And that, in fact, is the executive function that recruits all of the other executive functions. So I like to start there. I don't like to start with pathology. I don't like to start with, let's get rid of cutting, let's get rid of this, let's get rid of that. And if you look at a DBT target list, I think one of the things that can unfortunately bias DBT therapists that way is that you look at the target list and it starts with, well, you decrease this, you decrease this, you decrease this. Well, no, the first target is actually pre-treatment, and it's increase, a commitment to treatment. To me, that starts with increasing a sense, a clear visual image of a life worth living if you can get it. Though with I got a little more of one with you than I get with some people that have BPD who can't even envision any image other than getting through today. But that's where I start. Then I build backwards from that into what's getting in the way of that. And that's going to merge with my assessment of the presenting problem behaviors. So what's going to get in the way of that from her point of view, I think, was that she doesn't have friends and she thinks she's a bad person. Okay, but also she's trying to kill herself. Also she's hurting herself on a regular basis. Also she has an eating disorder. Also she has substance abuse. In other words, there's multiple things that are interfering with her getting a life worth living. She may not agree with me that all of those things are interfering, but that's my frame of reference. So I'm going to line up the problem behaviors now as the obstacles on the way to the life worth living, and then I'm going to start to shape down to the first highest priority target there. I guess all of this is making my first point. It's behavioral. DBT is a behavioral therapy. And behavioral therapy means, I even have worked with, I think, people who, unlike me, started out as CBT therapists that are really dyed-in-the-wool CBT therapists. I'm sort of a hybrid. I started somewhere else, and of course it still influences me. So I kind of see it in this very sharp light. I sometimes see CBT therapists that I don't think really get what it is to be focused directly on behavior. The only way to change behavior is to change behavior. You can't, in a behavioral model, that's how you change behavior. You don't change behavior by thinking about it, even though that might be a pathway. But you want to have at the center of your therapeutic alliance, your collaboration is, we're here to change behavior. Now we're going to accept it on the way, we're going to do dialectics on the way, but we're changing behavior. That's our only meaningful outcome. All right? Great therapeutic relationship without a big behavior change, that's not a good outcome. Right? So I try to weave that into my first session. This is all about changing behavior, commenting. So I oriented her quickly to the various problem behavior categories. This, and this. I was kind of doing a quick orientation, partly to establish credibility, partly to teach her this is a treatment model that's not based on finding your deep inner self and changing it, finding your internal conflicts and changing them. This is a model based on identifying the behaviors getting in the way and changing them. And so that I did first. Second, when getting a commitment in DBT, you want to start with that highest target behavior. And the difference, I loved it that you said, well, I'll try. Because, you know, it's like if you've been trained by Marsha Linehan, you're just waiting for someone to say that. It's like a reflex in DBT. No, try is not it. Do is it. Do is it. This is not a treatment to enhance trying. And so if you accept trying as the behavior of interest, then you're going to reinforce trying. That's not the same as reinforcing success. And it's great that she has a gymnastics background that I was able to think of at that moment, because no great gymnast thinks that the goal of great gymnastics is to try. So it's do or die, and she knows that way. And that's kind of like her life history. If I thought of it then, I would have said that. That'd be a great motto for her, do or die. So I really sort of took her and said, no, I'm expecting you to make this commitment, and I know it's going to be hard, and the whole treatment is going to get you to do this. But that's what we do because it's a behavioral treatment, and if you commit to that behavior, it's going to drive you crazy, and then you're going to drive me crazy, and then I'm going to bring the treatment to bear on it, or I'm going to coach you, we're going to teach you skills, etc. So, I mean, I think in a way, in a half an hour, we set up the treatment. And we've begun to pattern the treatment. As somebody who started out with a psychoanalytic model, I know how hard it is to try to jump ship. If you start treating somebody in a psychodynamic therapy and then decide after a while, you know, I think this would be a good DBT treatment, I dare you to actually jump there. I mean, I've done it. I did it at the beginning of my DBT career. It's very hard. And I think that patterning is established in the first session. I want her to think of me as a very high expectation, behaviorally oriented, but forgiving person. I passed the first test because I didn't kick her out in the way I brought it up. So those are a few opening comments we have. I figure, you know, it's been about 40 minutes. We probably have 20 minutes left. So I could go on, but I don't want to go on. I just won't know what's relevant to you. So comments, questions, and also this can involve asking Katie questions too. We have that privilege. Yeah. In my what? Yoda? Oh, is that a Yoda quote? I love it. Yes, all right. Yes, I'm Yoda. Yes. Did everyone hear? By the way, I think they set up mics for future questions. I just didn't catch it quick enough. But in the future, did you hear her question? I'll just, why don't you just state it again capture it again so everybody hears it.
So my question, is this on? Yes? Okay. So my question was, if you're going to frame things as either you do the new behavior or you don't do the new behavior, and you don't get credit for trying.
Yeah.
If the patient does have a relapse or slips up, how do you avoid that kind kind of framework you set up from turning into a black and white self-hatred, I'm a failure.
Yeah, okay. So the main way I avoid it is I don't think of it that way. Let me tell you, because this only got part of my thinking, because I'm upfront asking her for abstinence. But most people who've studied DBT very much know Linehan's concept of dialectical commitment. Right. And so this was part of that dialectic. Part of the dialectic is, God damn it, no cutting, no suicide. You know, it's going for broke, right? But in the back of my mind, I know that there probably will be relapse. There probably will be cutting. There probably will be, she'll give this up, this thing she's agreed with in this 20-minute time frame. So I know that, and therefore, if she asks me anything about it, I mean, I did, first of all, I got a little forgiving. I moved back away from that a little bit by saying, you know, we're gonna have ways of working together. I mean, for a patient who's been in other treatment models, to come in and hear from somebody, I'm going to be able to call my therapist, that's a massive change for most people, you know, and I already framed it as a few-minute telephone call to help you get back in the game or get back on track. So she already knows that even though I'm saying we're going to go for broke, I'm expecting you to do this, that I'm going to play a part in helping her with this. But if she were to push me, and usually it'll happen, but what if I do? Does that mean that I've failed treatment? You know, then I'm going to fall back and say, you know, if that were to happen, we're going to deal with it. We're going to figure out what caused that to happen after you've made such a good, strong commitment, and then we're going to get you back on board. But it's going to be, if that happens, we're going to put our minds together and we're going to sort this out, and we have a way of doing that. It's called behavioral chain analysis. We're going to figure it out and figure out what the solutions will be. So then she'll know that. And I think this dialectical commitment idea is challenging to do, because you don't want to be black and white. Right. I mean, I don't know what her gymnastics coach was, but I don't want to be the replication of a gymnastics coach that was black and white. I want to be black and white and forgiving, black and white, and have a backup plan, a relapse prevention plan. So, yeah, I think the main way I remedy that, I don't worry too much about it at this stage, but I know where I stand internally, and so I know I'm going to communicate to her that it's also, it's forgiving if that happens. I'll tell you where I first learned that was Otto Kernberg, interestingly, because one of the things that Kernberg and Linehan both taught me, maybe slightly different words, but not that much different, is that on the one hand, as Kernberg first taught me, you basically treat the situation as urgent, in need of immediate help. We got to do it now, and to be infinitely patient. You know, and Linehan, it's the same thing. It's like, we got to get this to change now. Change this behavior right now. And so I'll find myself saying lots of things like, this has to change right now. Of course it doesn't have to change right now. Who says it has to change? That's my view of the universe. It has to change right now, you know. And of course I know it might not change right now. So I have to be ready for the backup plan. Okay, Great question. Thank you.
First of all, as an educator, 30 years of education, the model, the dialectical behavior therapy model, is very much like the model that a good teacher uses with a student, actually. They set the structure, they have very high expectations, and yet continual forgiveness for individual problems and moving forward. So I always find that interesting, that a good teacher very much always practices this kind of dialectical approach with children.
Yeah.
Secondly, I'd like your opinion about a research-based dialectical behavior therapy, which does not include the opportunity for the person to speak with the therapist when they're experiencing difficulty. Do you see that that would be a major problem in terms of practicing an effective therapy?
Say it again.
A research-based dialectical behavior therapy by trained therapists without the opportunity for the person to access the telephone communication with the therapist when they're in deep trouble.
In other words, what do I think? I mean, if you set up DBT, And if the understanding of the DBT model and the evidence that has accumulated around DBT is all around a model that includes being able to access the therapist now and then for coaching purposes. If you take that, of the 5 functions of DBT and the 5 main modes of outpatient DBT, you take that out of the mix, now you've got 4/5 of DBT. Actually, you might have less than 4/5. So it might work. It might work with some people, but it's not the evidence-based treatment. So I've had patients that barely make phone calls that have done well. I've had other patients that make lots of phone calls that don't do well. But what I'm talking about right now is not what is, I'll say this provocatively, I'm not talking about what's good therapy, I'm talking about what's DBT. A DBT has 18 randomized controlled trials to support it. So that's pretty good, but it still doesn't mean in a given case it's the right therapy, I mean, from my point of view. But if you're going to do DBT fully, comprehensively, to the evidence-based model, they definitely need to access that coaching. A lot of teams set it up so that you can access somebody else for coaching. You know, like call a crisis team that has a DBT protocol. You know, that's sort of like choice number 2, I guess, but it misses out on a lot. I can do a lot of work in 2 minutes on the phone because of the attachment and because of the mutual knowledge and the history together and my knowledge of what skills work for them and what reinforcers work for them. I can do a lot more in 2 minutes than a crisis team can do, or than someone else on my team can do. So it's a very valuable, in some cases it's been the turning point of the treatment, is somebody after a phone call learns they can go 20 minutes with intense emotions, not hurt themselves, and come out the other side. That's a new learning experience. So if you don't get the coaching, you might never get that chance. Thanks for the question. Yeah.
I agree with you that it can work very well to have patients have your phone number. I'll even give them my home phone number and sometimes my cell phone. But I've been surprised, I guess, that patients are usually pretty judicious in how they use it. There are some who do need a little guidance on that. But I just wonder if you want to talk a little bit about how you structure the situations, both in terms of them understanding when they should call you, as well as just what your approach is to the phone call in terms of how long you take, what things you talk about, things like that.
Yeah, good question. Well, I was a basketball player for a long time, and my structure comes from the 60-second timeout in high school basketball on Friday night. Because the 60-second timeout when you come off the court is often because the game plan is not being executed according to plan and things aren't working very well. And the point of those 60 seconds is to get the game plan back in place, all right? It isn't to go over how are things going, guys. Somebody comes in and says, I don't like, Johnny's not passing me when I'm free. I'd say bring it to practice. We have 60 seconds to get back on the game plan. How about this, how about this, how about this? So that's my model. Now, I never do it within 60 seconds, but it's concise, it's a coaching model, it's a getting on the game plan model. My patients learn that because when I first start treating them, I orient them before there's ever been a phone call, and I usually do a role play or 2 in the session before there's a phone call so that they can see, if you call with this or if you call with that, here's how I'm likely to handle it. Here's the point of it. The point is coaching. The point is to how to get you to access some of those skills that aren't in your mind or aren't in your mind yet, and get you to have a successful experience of using DBT skills to cope. And that's the point of it, and that is the point of it. Extended therapy is not the point of it, even though that might be desirable, and I might even feel like it sometimes, but that's not the point, so it has to be limited and focused, and then you and I have to check it out in the next session. Did it work for you? Did it work for me? Because this is a vehicle that's unusual in treatment, and we want to really make it work, and we don't want to just have it be another conversation. And if it doesn't work, let's try to talk about how to make it work. And the topics I talk about are, I try to get very quickly to what's the problem now, since I just saw you the other day. What's gone on? I try to, within about 3-4 minutes, I try to get a little capsule summary if I can. That's if somebody's talking. Sometimes you get a call and somebody doesn't talk. That's what makes it a little more difficult. So I just try to get clear about what's happened. I try to stay away from any looking at why am I so sick? Why is life hopeless? Why should I ever try this since nothing ever works? I say all of that's good game for psychotherapy sessions, but actually that's not the reason to call me. That might be the reason to go to a crisis team or an emergency room, and have a big conversation, be evaluated. But that's not the point of talking to me. I'm a coach. That's how I sort of frame it. I could say more, I could do a role play of it, but I think in a short answer, that's probably the best I can do. Other comments? Don't pass up the opportunity. Though I'll be here for 2 days, so I'd love to talk to anybody what you thought of the interview and certain moments in it.
A minute ago, you hinted at maybe DBT wouldn't be what you would use for everyone.
Right.
What categories or what would cause you to think that it's not going to work for someone?
There's probably the DBT answer to this, and then there's the answer from somebody who actually started with another model of treatment. I think that no treatment's going to work for everyone. And I don't think anybody has yet identified who are the right patients for DBT. In New York Hospital, when I started a DBT inpatient program, I left the object relations program to go do the DBT program, right? And in the hospital, we try to figure out who should go to which program. And both programs thought they were best for the same group of patients. The ones who were really smart, who didn't have, who were capable of insight, turn out to be the same ones often capable of behavioral change in a shorter time frame, who are interesting to work with. I mean, everybody wanted to work with the same one. Oh, these are DBT, but the psychoanalytic unit came to feel that the DBT program was the broad spectrum antibiotic. It can do a broader spectrum of people because it's a more supportive kind of therapy, and there may be some truth to that. I do think that I can work with most people with DBT, but there are moments with some patients or with a new patient that I think, I can remember Kernberg treating a patient like this better than anything I've ever seen, and it might be the incredibly bright, sharp, emotional, paranoid individual that I would watch him treat and I'd just be dazzled. And because he had ability to be direct, blunt, upfront, and not to ask for much behavior change, but there was a kind of a structure and focus on the transference, focus on the relationship that I think was good for that kind of patient. I do have, and I've had patients that really almost never, they have one or another problem that interferes with being able to take and run with what we do in therapy and do it outside, that generalization of what we learn inside to outside. So sometimes I think people like that, you try to figure out what's interfering with generalization. But sometimes people like that really benefit from a rich focus on the relationship for a good while. Almost like I saw, some people are writing about stepped treatment, where you start with one model and you move on to another model. But it's a murky answer to your question. Your question's great, and I don't yet have the answer. So I'm going to stop there and admit ignorance. Yes.
So I had a question really about your therapeutic stance, because from the psychoanalytic point of view, you're much more direct and present. But from my, I noticed that you were relatively emotionally neutral. You didn't make a direct empathic statement to her. You you expressed empathy by virtue of saying, well, when she said, my 22-year-old sisters are everybody's so successful, and look at me, I'm crap. And you said, yeah, that would feel like I would feel like shit in that position. So
Yeah.
you made a statement sort of owning how you might feel.
Yeah.
But you didn't make a direct empathic statement of understanding her pain or her anger. And I wondered, is that a deliberate stance? And in what purpose does it serve not to directly validate her specific subjective experience at that moment?
Yeah, that's a really good question, too. You can't do everything in a half hour. So if I'm going to start a treatment, I want to capture what we were talking about before, that I want it to be clear. This is going to be behaviorally focused. It's on doing, not trying. It's on these behaviors, not that. And also, I am going to be validating. I'm going to be compassionate. I'm going to be forgiving, so to speak. but that's not my first step. Now, I find it interesting that if you look at, having come from a psychoanalytic model, that Marsha Linehan started with a real CBT model, and she moved from it to become a modified CBT model. And what did she bring into her model that modified it from straight, problem-solving treatment? Validation, and a style of communication that's warm and responsive and genuine and with some self-disclosure. Things that weren't necessarily immediately stated as part of the CBT repertoire at that stage. She sort of moved behaviorism she sort of brought in something that makes psychodynamic people feel like, I do that. I could see that in DBT. And if you look at what Kernberg did, starting with straight psychoanalytic treatment, which is more what I had during my psychoanalytic training and my own psychoanalytic treatment. It was pretty like straight classical psychoanalytic treatment. Kernberg moved towards being more behavioral. He set up contingencies. He set up structures that other analysts didn't. He talks way more than other analysts do in sessions. I mean, his model, and not than all analysts, but certainly what I had experienced. And he challenges people in certain ways. So he kind of moved in a behavioral direction. And my learning from that is that almost any treatment model is going to have to address some of the same challenges. So if they only cover behaviorism, they're going to have to move a little. If they only cover psychoanalytic insight and empathy, they're going to have to move a little. And so, but if it's a DBT model that I'm modeling, I'm going to model starting out with CBT and problem solving as my centerpiece, and then I'm going to build mindfulness, awareness, validation on top of that, and I'm going to build dialectics on top of that. So these are the three paradigms, but the core paradigm, the center paradigm, the paradigm with a goal in it, the paradigm by which we measure whether we succeed is CBT. That's sort of why I emphasize it. Got another time for another question or comment?
This is a question for Katie. It was clear that you were getting a lot of pressure to make that commitment to, excuse me, to not kill yourself for a year. And I wonder, from your perspective, if you just felt like, I have to cave, he's not going to give in here, or if you had a genuine change of heart that you really wanted to make that commitment. And if it's the latter, if you have a sense of when and why that happened for you.
I definitely felt a sense of commitment on his part, that he was committed to helping me if I was committed to this. I think I asked something like, if I don't commit to this, would you still work with me? And his response was more vague, but it definitely, the question that you asked definitely left room for him to backtrack a little bit and be more genuine and like not have that black and white thinking. And it was more open-ended, his response, so that switched me into thinking that if he's still able to work with me, if I didn't commit right now, I felt less pressure, and I felt like I wanted to make that commitment for our relationship. So I definitely felt a switch happen. I don't know. I mean, I don't know if someone with BPD would, but I did.
No, I think you're not that different.
Thanks.
None of us are that different.
Yeah.
No, it's just human responses. Yeah. I really like the way you put it, that it isn't that I'm asking for commitment in a vacuum. I'm asking for commitment along with my evidence that I'm going to be committed, that I'm offering this, that I have a structure for this, that I have some confidence in this. And I think that sometimes the validation, and those of you, I mean, DBT trained people know the concept of functional validation. So functional validation means that you communicate or you respond in a way that indicates that you have a grasp of the person's needs and their situation. And sometimes the best way to validate is that you communicate it by saying, we've got to solve this, and you've got to commit to this, and I'm going to commit to this. That can be more validating than saying, you know, I want to understand your anger, and no wonder you feel angry. I mean, that's validation too, but really validation for somebody who for 10 years hasn't been able to turn things around is to say, God damn it, we're going to turn things around. We're going to work on this. That's validation. And so it's important to realize that sometimes problem solving is validation. Look, this was a privilege, again, to be able to do it. I'm really deeply grateful that Katie put herself out and got up there and did this, so thank you so much. And like I say, I'll be here today and tomorrow, so I would welcome any sidebar conversations about what you saw, what you thought, what you wondered that we just didn't get a chance to get to. So thanks a lot, and I'll turn it back over to Mary and whatever comes next here.